Dear colleagues, thank you for this opportunity to contribute to the conference. I regret that I can't be there in person as the arrangements did not work out as we would have wanted it to. I'll be speaking to the topic of culture and health promotion, and then specifically in a person-centered way. I take it that in person and people-centered medicine, cultural values should be accounted for in considerations of health promotion, and to do so, I'll be considering culture and its related concepts, conceptually drawing on value theory and ethics in articulating a person-centered framework that clarifies and differentiates between the concept of culture and its related concepts in practical approaches to the promotion of health. PCM, person-centered medicine, puts the person and people before their culture in the promotion of health. Yet, by virtue of doing so, the cultural values of the individual person and people collectively should be accounted for theoretically and practically. To do so, the conceptual scope of culture should be considered. I want to kick off with an anecdote to illustrate this. So the little anecdote is of a casual conversation that took place in public in the United States of America. My sister-in-law is South African who has been residing in the United States for the past 13 years. And the speaker here is from the USA, and my sister-in-law was referred to as it's interesting to hear how you cultural people speak. So this person from the United States said this to my sister-in-law. So how may we think about this? My sister-in-law was referred to as you cultural people. What seems to be supposed by the speaker in you cultural people? Now, it's clear that the speaker is ascribing the property cultural to people different from the speaker. And perhaps the speaker may take a superior position or even a condescending position in that. But what I would like you to spot here is the blind spot of the speaker, as if the speaker is not also a cultural people of sorts, albeit different than my sister-in-law. Before returning to this blind spot for one's own culture, I would first like to consider 5 faulty or misleading understandings of culture. Sometimes culture is understood as a group, an ethnic group or a race group or a religious group or even a tribe. But there's a better understanding of culture adopted by anthropologists, and that defines culture as, or define culture in terms of shared practices. Rather than a group, it considers culture as a shared practice or a set of shared practices, and that constitutes that set of practices, or that practice constitutes then the culture by virtue of a uniformity in those practices. And as we will see later on, we typically notice this culture or a culture when different from another culture or another practice or another set of practices. Cultural groups may be better considered as conceptually derived from uniform practice, rather than to think that practice derives from the cultural groups. So notwithstanding that cultural groups sometimes identify by virtue think that some uniform practice result from the cultural groups, those cultural groups are actually constituted more so in terms of the uniform practice than the uniform practice being merely a result or a feature of the cultural groups. To think of culture as a group is like the tail wagging the dog. And to think of culture in that way is at risk of exclusivism and or reification of the group. So we may think of the group as the identity that result from the shared practice, ways of doing, if you wish. It's an alternative and a better way to consider what a culture is. Sometimes culture is necessarily referring to, is thought of as necessarily referring to a geographical locality, as if culture is necessarily, geographically defined to a tribe somewhere, for example, like that. DSM-5 also makes this mistake, but there are various examples of cultures that are not geographically confined to one or other locality. Think, for example, of the following international or global cultures. A diagnosis-making culture is a culture to which most clinicians, for example, would describe. A scientific culture, the Renaissance culture, the internet culture, the 20th century culture, the smartphone culture, social media culture, the culture by which we Google if we've got a question, the Googling culture, and we may add many to these, are shared practices, and by virtue of these practices we identify a particular culture. The third misunderstanding is that to think of culture as merely being a set of symbols and language. And certainly culture finds expression through symbols and language at times, but not necessarily so. So for example, the Googling culture is not necessarily a matter of symbols and language, but again, a practice. So to think of culture merely in terms of symbols and language, or symbols or language, would be mistaking the trees for the forest, or mistaking words and sentences for the meaning that the sentences and the words express. Philosophical way to articulate this is to say one would be mistaking the reference for the referent. So symbols and language are not an adequate account of culture, or of that by which culture is constituted. It's not the full story. The fourth misunderstanding is to say, well, I think that's a subculture, but a subculture can only be such in relation to a culture. So the question is, of what culture would this be a subculture? And if there's no merits, if there's no such a relation, then one cannot really speak of a subculture, because the culture would be obscure and even non-existent, and the term subculture really is not sustainable on closer scrutiny, and one may consider so-called subcultures as a culture in itself, even if related to other cultures. So the concept culture ordinarily suffices without resorting to subculture, unless the relation of some set of practices is important as part of a bigger set of practices. The fifth misunderstanding is to think that culture is fixed and merely an expression of history. Certainly some shared practices or cultures have a long history. Some shared practices may even be relatively new, though. And also to realize that shared practices are generated in current times. So we are generating culture also in current times by virtue of that shared practices. So this blind spot, which I've alluded to in the anecdote, there's a good reason for this kind of thing happening, where the person only attributed culture to someone else, apparently blind for her own culture. And this tendency was well spotted by the philosopher R.M. Hare in publications 1963, 1952, Oxford philosopher. And he says, values that are shared may easily go unnoticed, even though they determine appropriate action. So perhaps we may demonstrate this in a heart attack example. This is an example commonly used by Bill Fulford, philosopher and psychiatrist. And I'll demonstrate it as follows. Let's say I were in your presence and I developed central chest pain and became rather bluish in the face, such that it was clearly that was having a heart attack, myocardial infarction. And, in that situation, the question would not be to the, in the audience, is there someone who could tell us what the value is operating here? That would be rather far-fetched. It would be quite obvious that you would jump up and rescue me. And it would jump up and rescue me because that situation where I develop such symptoms would be considered bad by anyone's take. So it's a bad condition. The value is that it's bad. But you don't need to think of it as bad. It's so obvious that it's bad that you could simply just act on it and would jump up and hopefully try to save me. So the value there, that situation is bad, necessarily guides the action. You jumping up in attempting to rescue me. Even though that value, that situation is bad, is operating tacitly. So we values typically when they are different. Fulford describes this as a squeaky wheel. The wheel that squeaks signals a problem. That's, with the old ox wagons, the wheel that squeaks told that was the wheel that needed the grease. So cultural values are assumed to be uniform or the same. So we've got this blind spot tendency until they squeak, so to speak. And there are various ways of cultural values squeaking. When there's overt conflict between cultural values, but sometimes also silently between the parties, giving rise to some alienation. So conflict or silent alienation results from different culture values, and these may go unrecognized in, for example, interaction until that presumption of cultural uniformity is challenged. So just to summarize what I've been saying is, uniformity of cultural values is definitive of a specific culture. A culture is so identified by virtue of that uniformity in practice. But we notice that very culture by virtue of differences in comparison with other cultures. So we need both the similarities and the differences to identify a culture, and it's a similarity and difference in practices, in what we do. In relation to clinical practice, we are presented with a meeting of at least two cultures thus, the clinicians and the patients. By uniformity, each culture is constituted. By differences, the distinct cultures become visible. So how may we go against this tendency to have a blind spot for one's own culture? The simple answer is that we need to recognize culture in its full scope. And we can begin with various observations that have been well established empirically, that the connections between culture and health are varied and profound, Culture, for example, affects various illnesses in their symptomatic expression, how that presents, how it is experienced by the patient, how it's interpreted, how it's the cause and outcome are affected by the by culture. Culture may mediate and moderate individual resilience, coping mechanisms, and one's social response in recovery from health problems. We may also recognize that each person comes with a set of practices, with his or own culture and cultures, belonging to various cultures, and so does the patient. And when the clinician and the patient meet, that is a meeting of various cultures. We should recognize that if we want to go against this blind spot tendency. Also in the promotion of health. If I say promotion of health, I include the prevention of illness and the fostering of well-being, consistent with the WHO definition of health. So when we recognize culture, that should include recognizing one's own multiple cultures, rather than succumbing to a tendency to have a blind spot for one's own culture. So that one knows, as a clinician, I come with the clinician culture as well as various other cultures to which I belong. And that then is a meeting with the patient and his or her set of cultures. When we recognize culture in the promotion of health, that requires practically that we account for the various cultures, the various sets of practices in our interpersonal engagement, and that we reflect in that engagement on the various cultures or practices. So it's a reflection on the cultures, and it is also then a meeting of those cultures. An emerging culture in the current pandemic is, of course, that of virtual meetings. A virtual meetings culture we may speak of, which is a culture that has emerged in occupational practices. We've got new ways of engagement among employees, for example, new ways of engaging with patients and health service delivery, and in doing health promotion. Through, for example, the culture of virtual meetings. We may even speak of a health promoting culture, again, as a set of practices that defines health promotion. Now, this may be formally pursued as a culture, that is the culture what we do, and realize that promotion is based on a meeting of various cultures as a conjoint venture between patient and clinician in shaping this very culture. Of course, this culture is informed by evidence, scientific evidence, but would be great and best for avoiding that blind spot if we account for the differences between the values, including the differences in cultural values in that process. So I conclude, a person and people-centered approach to health promotion should not conflate culture with group identity, ethnicity, race, locality, symbols, or language. There's a difference. It should not recognize the culture of merely others, but recognize that each and every person is necessarily embedded in a set of practices, shared practices, thus necessarily embedded in culture and cultures. Instead, a person and people-centered approach to health promotion should recognize and account for the various cultures of all the stakeholders, and also that joint efforts constitute a meeting of cultures. I thank you.